We'll move to the second section of the agenda, 4260, Department of Health Care Services. And we'll welcome before our committee for the first time, Ms. Kent, the new director. Welcome, Ms. Kent.
Good morning.
We've got several as in 16.
It's a big department.
Big department, big number, and meaty issues.
Exactly.
That we will discuss today. And we'll start on page 14 of the agenda with an overview of the department. And again, welcome.
Good morning. Jennifer Kent with the Department of Healthcare Services. And with me, I have Mary Cantwell, Chief Deputy and State's Medicaid Director. So I will do the overview and I will speak to the CalHERS item. Mary's going to cover the caseload estimate and the other issues within the hearing agenda today, unless that's okay with you. So just quickly as an overview, obviously, Department of Healthcare Services runs the state's Medicaid program, otherwise known as Medi-Cal. We are excited to say that we are upwards of 12.1 million individuals as of our close of last month's eligibility. So I think, speaking to the success of the Affordable Care Act, we have certainly done what we set out to accomplish in terms of providing more coverage to individuals. That's a 3 million person increase over the last 18 months. And as of today, we cover 1 in 3 individuals in California. Outside of Medi-Cal, we have several other programs, including the California Children's Services, the Genetically Handicapped Persons Program, Breast and Cancer Cervical Treatment Program, and IMPACT, which is a very small program but aimed for men with prostate cancer. Obviously, as you know, we have undergone significant transformation in the department over the last several years, not only related to the Affordable Care Act, but also to the fact that we have absorbed 3 other departments and their programs. Department of Mental Health for the community mental health issues, the Department of Alcohol and Drug, and Mr. MIB, and we have absorbed the former Healthy Families Program and AIM. So with that, it has been a lot of change.
It has.
We stand at $98 billion in federal funds, and we have approximately 3,700 positions in place today. We're seeking approximately 79 new positions through various BCPs with your committee and with the Assembly as well. So with that, that's kind of the big overarching description of what the department does and handles. There was a question in the agenda asking us about our designation as a high-risk agency recently by the California State Auditors. The department has actually been a high-risk agency since it was split back in 2006 when it was Department of Health Services, and we went to the Department of Healthcare Services and Department of Public Health, and that high-risk status has never been removed. Obviously, given the amount of dollars that we have, the amount of programs that we run, and some of the ongoing audits that have been noted with the auditor, including dental, mental health, and Denti-Cal or drug Medi-Cal, or not Denti-Cal, drug Medi-Cal, we acknowledge that there are a lot of consequential programs and funding sources that would place us in that category. And so we take the auditor's recommendations very seriously. Some we're able to implement, when they make audit recommendations, some we're able to implement fairly quickly and some are longer term. And so I believe that's generally the reason why the high-risk status has remained, in that we have not been able to fully implement all of the recommendations for some of those audits, but we have timelines in place and processes for how we're going to get there. So with that, I will stop and take any questions on that.
On that same point, I would just ask, as the newly appointed director, you want to spend a little bit of time talking about what your priorities are, particularly in the context of the auditor's report,
Sure.
Focusing on those areas that have been deemed
Sure.
high risk.
Sure. So I think actually to the second item that I'm talking about on your budget today, CalHERS is one of the things that I very quickly identified early on, that it's a very big, complicated process that we're going through. It's an IT system that we share ownership with Covered California. The Office of Systems Integrations is helping, obviously coordinate the effort between the two entities, but to the extent that we have 12 million Californians in coverage today and that they have annual redeterminations, I'm very cognizant of the fact that the work between our state staff and then the county eligibility workers there has to be an electronic system that works for everyone. And so I think that we are still growing that system and moving it greater and greater into more functional purposes, but that clearly it has to work, because if it doesn't, then we have big problems. So that is one of my clear priorities. The other one that I testified to the other day in the legislature was our Dent-a-Cal program. There was an audit that was made in December of 2014, so I had seen it before I took the job, and I still took the job. But I am, we accepted the recommendations, and they're fair recommendations, but I think that that's also a program that is going to require some, more enhanced oversight, and we need to implement the recommendations that the auditor made. But I think it also just speaks to the fact that we have a program with individuals that need to ensure that the coverage is actually meaningful, and so to the extent that that's areas of improvement, that's one of my second priorities. And then lastly, I would speak to the enhanced need for stakeholder process and communication back. We have a lot of different stakeholder meetings and a lot of different work groups, because we have a lot of programs that are going on, and it's not enough to just have a stakeholder meeting, but it's incumbent on us to have a developed process. We need, a clear agenda. If materials are available ahead of time, which they usually should be, we need to give people a chance to look at what it is we're wanting input on. And then clearly improving the back-end communication with stakeholders, which is, if they're giving us advice and recommendations on how to either modify or change that proposal, we need to do a better job of explaining why and how we came to that decision. And so I've got staff working on both a process, as well as we're going to be probably repurposing and using some open vacancies now to recruit, to help kind of bring a more consistent, cohesive process, as well as do some of the administrative work to make sure that we respond to individuals when they do submit either comments or ask for follow-up.
Excellent. This was the director's overview, and we're going to spend time, as per the agenda, getting deeper into CalHERS and dental services. So we'll have an opportunity to follow up when those agenda items come up. Senator Stone.
Yeah, thank you, and welcome. Looking forward to your overseeing this agency with $98 billion of federal funds. I know that about 9 or 10 years ago there was some instances of fraud within the Medi-Cal system, which was a little bit pervasive, and I think the state's done a good job of trying to weed out the fraud. Where does that fit in your agenda to completely root it out? When you're talking about $98 billion and you hear complaints regularly from providers, we don't get paid enough. Unfortunately, that can instigate a little bit more fraud for people feeling they're entitled to a little bit more money than they're receiving. So, where do you see resources being dedicated to make sure we eliminate fraud where we can?
So we have, and I think Karen Johnson's in the audience. She's my other chief deputy of the program that oversees the audits and investigation staff. It is one of Karen's, well, first of all, when I moved into the office, when I was actually moving my things into the office, she was trailing behind me and actually telling me some of the activities that she's been working on as it pertains to audits and investigations. So I think it is one of the things that is fundamentally critical within the program. I think that there's over 700 staff within audits and investigations where this is what they do. I think that what she can speak to in more detail, as I'm talking off the top of my head, is the improvement in technology and data analytics has really refined the work that we do, and so we are able to do things that were never capable before in a fee-for-service environment. And I know that we have some briefings planned, with legislative staff and others about how we're bringing up our automated provider eligibility and application system, which in and of itself will also help us better understand who the providers are. And so, I can speak, broadly to the fact that we have people that are working smarter and better thanks to data analytics, and a lot of both vendors that we use for the analytics component, as well as our own investigative branch, is really on top of things.
I know through certain algorithms you can spot fraud, and certainly the electronic submissions gives you the tools that you didn't have before. I'm happy to hear you still have 700 people dedicated to analyzing data. And do you have your own sworn investigators that can go out, or do you work in tandem with the AG's office?
Good morning, I'm Karen Johnson, Chief Deputy Director, and yes, we do have sworn peace officers, and so when we do go out and conduct these field reviews, it is a multidisciplined team that does go out to conduct and perform these reviews, so it's comprised of an auditor, comprised of our investigator, peace officer, as well as our medical consultant or nurse evaluators.
And you do any kind of an annual report showing the legislature the fraud that is uncovered? And
So what we conduct is a medical payment error study, and that is shared out with the legislature, and it's done every other year.
Okay.
And so we've been doing that for the last 6 years or so.
Okay. Okay, I look forward to that report. Thank you.
Okay.
And do you assume that all medical payment errors are as a result of fraud, or is
No,
that distinguished in the report?
Yes.
It is distinguished in the report. We do categorize in terms of fraud, waste, and abuse.
Great, thank you. LAO, Finance, any comments? Public comment on the director's overview? Thank you. Seeing none, we'll move into Medi-Cal estimate and caseload, page 14.
Thank you, Mary Cantwell.
Page 16.
Mary Cantwell, Department of Healthcare Services. So there were several different types of questions to address here, so I'll try to touch on all of them. In terms of the caseload itself, we are projecting in the January budget an average monthly caseload of 11.9 million eligibles in the current year, and going up to 12.2 million average number of monthly eligibles in the budget year. This does include about 2 million adults who are part of the optional expansion. One of the questions asked was how we respond to some of the issues raised by the LAO, and certainly we agree with a lot of the issues that were raised, particularly how it's hard to estimate caseload right now. I think we've all seen over the last couple of years, we've blown past all the estimates we've had of expansion, and so it is very uncertain. We continue to monitor the data. We do think we're starting to see a bit of a stabilization. I believe this week or next week we'll be releasing our next monthly report on eligibility. You'll see it's for the first time pretty flat. So perhaps we're getting to a steady state where the estimates will be able to be a bit more reliable, but we're going to continue monitoring that and obviously updating that in the May revision.
Quick question. The enrollment period for Covered California was extended until when?
April, end of April.
Okay, and so as we've experienced in the first round, a lion's share of the enrollments were actually Medi-Cal eligible, and so you think it will still stabilize even though we've got an open enrollment period?
That's what we've seen. I mean, you know, I think that's exactly what we don't know, right?
Okay.
That's what we've seen over the last couple of months now, a little bit of a, you know, still an increase, but like 0.3% versus the many percentages. Exactly.
Okay.
But certainly what we've also seen at the end of open enrollment periods is a huge increase, you know, a push at the end. At some point,
Right.
as folks have heard me say, we have to run out of uninsured people at some point who are eligible. I feel like we've found all these individuals, which is great. But it has made our estimates challenging. And so we continue to work with that and continue to work with the LAO on and making sure that they understand the estimates that we're doing. You know, I know that there were two issues related to our trend on our family caseload too high given the changing economy. We do include an economic variable in our caseload estimates. We're going to continue to use that, and you know, generally, absolutely, as the economy improves, our Medi-Cal enrollment usually goes down, and so we'll continue to monitor that. At this point in time, we haven't seen that impact our eligibility. And then there was also an issue raised about the senior caseload and the significant increase that we are seeing in the current year. That is an actual increase that we're seeing, but we do project that will go back to normal levels of growth in future years.
And what I found interesting about that number is that that's not the Medi-Medis, that those are seniors who are Medi-Cal eligible, and that's significant increase.
It was a big spike. We're trying to understand why that happened. We think some of it may have to do with the delay in renewals that we had last year. That, you know, the normal sort of processing on and off didn't happen. But it seems to be bigger than that. And so we also think, I mean, you know, generally, as we just talked about, we've seen such an increase generally in caseload that there really is a culture of coverage out there in California. And so more and more people are just applying for coverage, and they find out, as you know, 3/4 of the people find out they're eligible for Medi-Cal when they apply through Covered California. And so I think that's part of the explanation as well.
And if there's some other future aha moment around that population, it would be helpful if you'd share that with either the Health Committee or Budget Sub.
Sure. So a couple of the other questions, in terms of the CHIP funding, you know, currently the budget does assume a reauthorization of CHIP. It does not assume the higher FMAP. the ACA included a increase to 88% FMAP from the current 65%. And so we really did try to take a middle-of-the-road approach in the budgeting to assume a reauthorization, but not assume the additional FMAP. We're optimistic as to whether CHIP will be reauthorized. It certainly has bipartisan support as a program. Obviously, if it doesn't get reauthorized, that will be a conversation that we'll all need to have about what we would do as a state. A couple of other things, we were asked to talk about the kinds of analyses we do to help address disparities and really identify where there are disparities in the Medi-Cal program so that we can then target our efforts along that side. We do have a lot that we're doing in that area. We have a lot of data that we are able to collect from our managed care plans as to the different demographics that we would want to stratify data by. We have begun doing that, stratifying it by race and ethnicity, age, language, gender, all those good things that we want to look at. This year we will begin stratifying all HEDIS measures by those demographics. We're also looking at presenting our encounter data, which is the data that we receive from our plans on cost and utilization of services, and start doing that by demographics as well so that we can see where are the differences in utilization across different demographic groups. And we've also begun doing our grievance and appeals. Are we seeing more grievances or appeals from members in certain areas so that we can identify maybe there's a problem going on there that might not show up in some of the other data metrics. We have published many of these in sort of presentations we've done to other groups. We are looking to start adding more and more of this to our quarterly dashboard. We do have a quarterly performance dashboard, really a unique item in the nation in terms of Medicaid reporting on Medicaid quality and health plan monitoring. And so we're going to continue to add to that and really use that as a way to show what's happening in our health plans and help to drive change.
Are the dashboard results shared with the legislature?
They are, yes.
In presentation, written form, how is that done?
So we do presentations, we have it publicly posted. We're happy to continually do that as much as possible and get information on what folks are additionally interested in seeing us add to the dashboard as well. And then finally, in terms of the renewals, as the agenda identifies, we have about 1 million people who go through the renewal process every month. We are working on collecting the data from the counties on the new process. There had to be a new system put in place in terms of the data we'd be collecting from our counties who are our partners in doing all of this work and do great work on that. And so we did develop some new processes to make sure we're getting the data in a uniform manner. So we don't have data just yet on the renewal process, but we do expect that for the April report of the ABX11 reporting that we will have some information available in that. Historically, we talk about how we've seen about a 20 to 30% non-response rate when renewal packages are sent out to individuals. We don't know yet what that will look like in the 2015 process. One of the things we do know is that the difference that we have with the ACA is that we do electronic verification of data, so we might not even have to send packages out to individuals. We also do pre-populated forms so that there isn't as much to fill out. And there is a 90-day cure period so that if someone does happen to miss that they had to respond to renewal and then they come off, but then they realize that as they need to get services that we put them back on the program as long as it happens within 90 days. So with all of those changes, we don't know yet will the 20% be the same? We believe it'll probably be less, but we'll see that as the data starts to come in.
Back on question 4 with regard to the demographic and disparities data collection. That's one step. The next step is actual analysis. And as a result of the analysis, then some kind of policy or programmatic shift. So will analysis be conducted as well?
Absolutely.
Because I've not seen the dashboard, so I don't know if the dashboard is just a collection of data or if it includes some kind of analysis.
Sure, so the dashboard is more a presentation of data, but we have a team who does a lot of this analysis, and there are some examples of where we've done analysis on sort of, say, maternity outcomes for African-American women, and we've then noticed that there are issues there, and so then we've issued corrective action plans with our health plans to say this is an area that needs to be worked on, and so that is the kind of process we're going through. And we do those more in sort of ad hoc presentations. We don't have them as part of the dashboard, but certainly that's something we can look at adding. How do we add more of the analysis into the dashboard?
I think that's helpful, to the general public, the advocates, and certainly the legislature as well. Finance, LAO.
Thank you, Madam Chair, Senators. Felix Su with the Legislative Analyst's Office. I'll be responding briefly to the department's overview of caseload issues. Then I'll turn over to my colleague Amber DG, who will be speaking to the uncertainty of federal CHIP funding that's also assumed in the budget. So on caseload, the department did a very good job summarizing some of the main points from our analysis. And we're also very pleased to see that they've resumed their monthly reporting of caseload trends on their website. That's what it looks like. And we think that these resources will be very valuable and make it more feasible for the legislature to independently track caseload as we move through the budget process. In terms of our analysis on caseload, we cover a variety of issues, but for my remarks today, I really wanted to focus on the families population and the projections for how many of these children and their parents will be enrolled in Medi-Cal through 15-16. But first, I wanted to come with a quick reminder as to why it's important to look at caseload in the first place as part of the annual budget process. Medi-Cal, as you may know, is the second largest program in terms of general fund spending. And part of the reason is because at any given point in time, there are millions of people who are enrolled in the program. Now, what this means is that even a slight relative change in the underlying assumption for the caseload trend can translate into a large difference in the amount of dollars that are budgeted for Medi-Cal. To give an example, the family's caseload is by far the largest proportion of the Medi-Cal population, even though on average, these enrollees tend to be the least expensive on a per-person basis. Now, if you were to assume that the underlying trend for families through 15-16 was, say, a 1% decrease rather than a 2% increase, which is what we calculate that the budget actually assumes, this would translate into 200,000 fewer enrollees, or roughly 240 million less in general fund spending. So even though baseline caseload assumptions aren't necessarily new policy proposals, they still are very much relevant and material to the overall budget conversation. Now, it so happens that the administration assumes that the family caseload will continue to grow at this modest rate of 2% through 15-16. And this does go against our default expectations. Historically, as Ms. Cantwell mentioned, families' caseload tended to go up during recessions and down during economic recoveries as people's incomes improved with the job market. And we're at a point in the current recovery where we've been seeing steady and sustained decreases in caseload for other major public benefit programs like CalWORKs. And we're just surprised that at this point in the California recovery, 5 years in, and with the most recent gains in jobs and the monthly employment reports being the strongest, that the administration continues to assume that the family's caseload would grow on its own even without the effects of the ACA. So it's for these types of reasons that we're withholding recommendation on caseload for the governor's budget in January. We point out that we have questions about the assumptions, and we also point out that these projections are based off of enrollment numbers through August of 2014. In other words, they're based on data that is over 6 months old at this point. We think the legislature should wait till the May revise before acting on the caseload adoption in the budget, because those numbers will be based off of more recent caseload trends through February 2015. Thank you.
Amber DG, Legislative Analyst's Office. As explained by the department, the governor's budget assumes a middle-of-the-road approach to CHIP funding within the range of uncertainty, and we find that that's a reasonable approach. However, depending what decision Congress ultimately makes about CHIP funding, the actual amount of federal funding may be higher or lower than assumed in the governor's budget. If no additional funds are appropriated for CHIP beyond federal fiscal year 2015, which ends September 30th, the likely general fund cost is estimated to be as much as $300 million higher in 15-16 than is assumed in the governor's budget. However, if Congress were to decide to fund CHIP at sufficient levels to provide the enhanced federal funding authorized under the Affordable Care Act, there would be general fund savings of roughly $450 million as compared to what's estimated in the governor's budget. We also find that there are longer-term implications for children's health coverage as a result of a potential end to the CHIP program. The Medicaid and CHIP Payment and Access Commission at the federal level has recommended that CHIP funding be provided for 2 additional years through federal fiscal year 2017. After that time, they see CHIP funding ending and children being transitioned into other types of coverage, such as ACA subsidized coverage. Given that, we recommend that the legislature begin to weigh the implications of this for children's coverage and consider options for children's coverage if CHIP funding is not continued over the longer term.
Quick question. Is there a population of children that would have qualified under the SCHIP rules that do not qualify under Affordable Care Act?
For CHIP funding?
Well, I'm thinking worst case scenario. The last scenario you gave is that potentially, let's say, SCHIP dollars go away in the 2 years, with the assumption that those children would be rolled over to ACA. I want to make sure that there's no population of children that qualified for SCHIP that don't qualify for ACA as currently written. Are there?
It depends what decision is made with regard to how to provide coverage for these children. These children could continue to receive coverage through Medi-Cal. There would be a higher share of state spending for that, but then that would not result in any lapses of coverage for the children.
I'm looking at primarily eligibility rules under both programs. Who qualifies?
If the decision was made to transition children into subsidized coverage through Covered California, it's possible that some of the children may not be eligible due to a so-called family glitch in the Affordable Care Act, where in families where a parent receives an offer of affordable coverage from their employer, but no one else in the family receives that offer, no one in the family is eligible for subsidies, so the parent could have coverage and the children could not be eligible for coverage.
Because under at least
California.
Healthy Families here, a parent, whatever their situation, they could pay for coverage for their child under Healthy Families, so I see. So that could be significant. Okay, thank you. Any questions, members? Finance has nothing? Okay, thank you. Public comment.
Madam Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty. And as an anti-poverty organization, we're not happy that 12 million Californians need Medi-Cal coverage, that they're poor enough for Medi-Cal coverage, but if they are, we want to make sure they're getting the coverage to which they're entitled. We do support the staff recommendation to keep the caseload number open until May revised for all the reasons discussed, in particular with the renewals. 2014 renewals were frankly a mess. With a very confusing form. Some counties have not even finished processing the 2014 renewals, so there are a lot of unknowns in addition to the economic recovery issues that the LAO has stated. We are very optimistic about the 2015 Medi-Cal renewal process, whereas Ms. Cantwell stated we've heard as many as 50% of folks are being basically automatically renewed based on data checks and told they're eligible. Great. So that's a terrific trend. Great. Just on the Issue B in the agenda, we strongly support the staff recommendation to eliminate the language on non-emergency copays. We opposed the proposal at the time. As noted, there is no federal approval for that, so we do strongly support that recommendation. We're happy to hear about the demographic analysis that the department is committed to do. That's very important for us to look at, and we appreciate the committee's attention to that issue. Thank you.
Next witness, please.
Tam Law with Health Access California. I echo the sentiments of my colleague at the Western Center on Law and Poverty. We also support the staff recommendation to keep the Medi-Cal caseload estimates open. We appreciate the department making the monthly caseload information available and believe that it will help the committee to make better decisions. And we also encourage the committee to ask the department to continue providing this information on a forward-going basis. And we also support adopting the placeholder trailer bill language to eliminate the non-emergency emergency room copay. Thank you.
Thank you very much. And if I failed to mention at the top of the hearing, ditto is always welcome in this committee. Next witness, 2 minutes.
Carrie Sanders with CPEN, also ditto to what everyone said. But we support staff recommendations to hold open the caseload estimates. And we're appreciative of the monthly caseload information. We really want to understand who is enrolled in Medi-Cal, and we really appreciate the demographic information. The last that we saw, October 2013, I think is the last full chart that we've seen of the entire Medi-Cal enrollment broken down by demographics. So, we would appreciate if I'm missing something and you can point it out to me, I'd appreciate seeing some more current numbers overall of the entire Medi-Cal population, because we do really want to understand who's in the program. I also just want to say thank you for being responsive to our requests on the information on demographics and health disparities and the stratification of the HEDIS measures. We've appreciated working with your office on that and look forward to providing input on the types of initiatives that you will be proposing to reduce health disparities. Thank you.
Thank you. Next witness.
Hi, David Thompson with Dental Surgery Centers here in California. And I also want to mention that we do appreciate all the work with the data, especially caseload estimates, as our services are directly impacted by this type of data. We also want to encourage people to track additional data points such as denials of authorization across the board, because this is actually would help us track a lack of access to care, because that is the care that is not being delivered. So including this data, which is extremely helpful, and the more data, the merrier. We love it. It helps us out a lot, so we also want to thank you for that.
Finance, you had a comment?
I do, I'm sorry. Yang Liu, Department of Finance. On the staff's recommendation regarding the adoption of the placeholder TBL, at the time being, we don't have any position yet, so just want to make a note of that.
Thank you very much.